The third exam goes to admission to medical school, done now by 2 of the 4 medical schools in Israel, and another dental school, and courageously trying to assess and select on sensitivity, maturity, motivation, aspects that cannot be really assessed in a 5-minute lip service interview. So we have 9 stations, behavioral stations, by which you don't talk about yourself, but rather show us how you behave. And we'll try to assess your suitability to this field of healthcare. And different types of simulations, simulation stations, simulation debriefing, and group simulation of 3 or 6 people in a room working together along the lines of the interprofessional field we have. SCORE is a combination of 3 behavioral and 2 judgment and paragraphic questionnaires that are part of the exam on the paper and pencil. Very strong evidence of reliability in this exam, Cronbach alpha of over 0.8 of the whole assessment center, pretty stable along the years. And Cronbach alpha and inter-rater reliability going up during the years to reach very, very nice agreement among raters. And test-retest shows nice stability of the individuals who retake the test a year after or 2 years after. In terms of validity, predictive validity is something that we're going to engage soon. Very difficult to do, I must admit. Some good data coming from McMaster along that line. Construct validity shows that there's almost 0 correlation between this exam and the cognitive exams that these smart candidates take before they are invited to this exam. And in terms of face validity, both raters and candidates view this as a fair tool to screen them into the field. And the consequences, 20% of the makeup of students going into medical schools in Israel have changed via this tool. Dramatic change in the atmosphere, very high national and international interest. We've published a paper on it 2 years ago. And again, the numbers are impressive in terms of the exposure of faculty and students to this field. And there's a moral message there that we all believe, not only to the candidates, but to faculty and to the public. We take it seriously. We're not there anymore to assume that everything goes well. The last example is nursing, and nurses have embarked into high-stakes assessment, the Israeli Nursing Authority, exactly 2 years ago. And nursing has been doing a lot of simulation, but mostly as education, but hardly anything within the high-stakes assessment. And it was a courageous decision on behalf of the chief of nursing in Israel to embark into advanced nurses assessment as they move on to those more senior positions in high-risk environments. And when we talk nursing, we're talking about 15 different nursing fields growing up all the time. We're developing this exam with groups of, according to a predefined test blueprint, with groups of nurse specialists, obviously, SIM experts from Messer, and psychometric experts from the Israel National Institute for Testing and Evaluation. 15 clinical domains to date: acute care, intensive care, PICU, OR, ER, etc., chronic care, psychiatry, geriatrics, nephrology, and beyond. 11 stations, OSCE, hybrid OSCE, actors, mannequins, combination of both, and many other type of stations. And once again, the numbers at the bottom in terms of the number of raters and participants that is, gives us all a sense out of the, as leaders in the field of nursing. Just to give you a feel, what does it take to make Messer look like an OR, 11 stations, OR-like, intensive care-like, neonatology-like, and many, many other setups that are so difficult, in fact, to put together for those type of exams. And each room, you can imagine how difficult it is. We're very proud, of course, of the last exam we just launched, which is the breastfeeding nursing exam. So we got about 20 breastfeeding mannequins, and our actors are breastfeeding these mannequins all the time, and everybody is very happy. So Psychometrics, just to give you a feel of the testing scores, over 52 testing days, just to give a feel of the wide range of spectrum, wide range of scores from bottom to up in the chronic care, in the acute care, pretty stable from 2009 to 2010. In terms of reliability, internal consistency, not in all cases we can get to high reliability because sometimes we have only 10 examinees. 10 examinees can never generate high reliability, yet we decided to go for it and not be slaves again to psychometrics. So intensive care, first year, 0.58, moved all the way up to 0.80. We are very satisfied with trying to improve the exam to reach higher standards of psychometrics. You see the same with midwifery and with primary care, the big fields where we have big N's. Rater agreement, again, less than 5% disagreement in the yes-no items, and less than 3% disagreement on the Likert scale of over 1 point difference. So we've done not bad in terms of the train the rater calibration process that we have shared with, in the workshop that we've done before. So going back to what did we learn? First of all, once again, the penetration. The penetration on a national level, Israel has about 150,000 healthcare professionals. We have penetrated or exposed this whole concept as a cultural concept to quite a few of them. Vertically, medical students in Israel, this generation, know what simulation is all about and the message beyond it. Because we're talking about over 80% of students are applying to all medical schools, so they will go through us. Same about faculty. Paramedics, anesthesiologists, 50% and above that have been in a simulation high-stakes environment. And a significant increase in terms of the simulation-based education. It changes curriculum. It changes the way we view our product lines and the process, of course, that goes with it. And a lot of groups out there now have simulators institutionally and run mandatory courses and or institutional simulation-based testing. So some lessons. First of all, I strongly believe that we need to really make the simulation-based testing an explicit goal. We are not there only to play with simulators as an educational tool. We need to think assessment all along. Formative, obviously, that's what we do, but we need to be courageous and think about it even for the application eventually to be done. It does require courageous leadership, ongoing courageous leadership on behalf of the regulators and the professional boards. They need to be ready to fight the cause and defend the move. Defend the move not only in public. Believe us, public would look at it as a trivial move. In fact, they're very surprised that we're not doing it. The defense is mostly within our own people. Within our profession, we need to defend this move, not even in the legal court. We've never been challenged legally, and Israel has its own litigious atmosphere, as most other countries have. So I think it's probably unfounded legal concerns that is one of the excuses that many of us use. Because if we will be legally challenged, I think it should be on the very fact that we are not doing it, and not on the fact that we are trying to do it. We need to dive into the water. Don't wait for the ultimate exam. It will never come. We need to work in progress and to improve and maintain structure. So improve in small increments. And we never need to forget that simulation is a complementary tool. It's not a replacement of the many good traditional tools that we're all using for so many years. We need to feedback loop what we're finding in the high-stakes exams, because we do identify deficiencies in the product line. We do that in anesthesiology. We do it in many other fields, because it does lead to changes of curriculum and to more focus on those deficient areas. Raters and faculty, after observing their product line, view how suboptimal their education was and perhaps become a little bit more accountable to what they're trying to teach and to train. A crucial aspect of success is the collaboration between the content experts, the simulation experts, and the psychometric experts, as I mentioned before. We do emphasize validity. The content, the construct, the process, sound process by which we develop a case, a test, We do aim at high reliability, but sometimes reliability is almost impossible to achieve because the N is too small. Is it a good enough reason to not test neonatology nurses? Or should we go on and try to learn from the larger N groups that we do? So it's not only logistics and cost, it's other considerations. Huge investment on behalf of all parties. The test development teams work very hard. Tough on the simulation center personnel, extremely tough to change the look of Messer from one day to the other, from 11 ORs to 11 intensive cares and 11 neonatology suites a day after. 25% of our doings this day is over 60 days a year is SBT. It's a lot, and a lot is invested in it. The high cost is it is costly. And it's costly, but it could be done top-down, as it was done initially in admission to medical school, and gradually we diverted the cost on the applicants. You want to be a doctor? Okay. You pay. We want to see that you possess the right traits. It's done in cognitive testing prior to medicine. Why shouldn't it be done in non-cognitive testing as well? Raters recruitment, not easy. It's an ongoing commitment. Retention, should we pay them? Should we not? We don't pay raters, but we make a point that we establish the rating position as a reputation and a prestige. In some of the cases, we're successful to the point that people call us and ask, why weren't I invited to be a rater in this case? That's good. There's a risk there that, the move into testing will threat the joy and the wow of the simulation-based education. It's a threat, but the more you're professional in the testing area, the more your trainees and examinees respect it. But it's a fine line. You have to walk there. In terms of research, we need to investigate, obviously, the psychometric qualities and, of course, the predictability value of this work in terms of its impact on patient safety, on curriculum, on faculty, on the motivation of people to do the job better. We need to improve the assessment metrics. We need to go and dive into the unmeasurable or the difficult to measure, as I mentioned before. By the way, not everything is measurable. And we need to choose those aspects that are measurable and to push ourselves on into the measurable, into the difficult to measure. So there's a concept here that we want to measure professionalism, but the same concept applies to us in the assessment arena. We need to apply professionalism on our assessment paradigm. And part of the professionalism is to do it right, to do it fair, objective, and so on. Standard setting, where do we want to put the bar? We now have 2 PhD students at Messer that are doing their PhD on simulation-based testing in nursing, in dentistry, and there's a lot of research that goes on that we're publishing in some of the fields. Measurement issues, assessment of the isolated skills versus the integrated skills, not easy, and assessment in different contexts that you need to create. There's never a chance for you to create all contexts, but you need to sample, obviously, as we all do. The role of simulation in multimodal assessment, simulation is just one tool. There's so many better tools and other tools for certain qualities. We need to integrate and choose the areas where simulation is really the one tool of choice. And we need to look into the role of simulation in maintenance of certification. Good work is being done as we speak. And of course, can we generalize from the Israeli experience in anesthesiology to an American experience in anesthesiology? Do we cross-fertilize each other in terms of the assessment model? Do we really teach each other what we learn? Back in Israel, anesthesiology paved the way. Paramedics benefited, nursing benefited, and of course, the whole field benefits each other as we move on and learn from each other in a single site assessment center. But I want us to keep in mind the very fact that simulated exams in the research arena are not going to give us the answers. Most of the answers will be, real answers will be provided in real exams, not in simulated exams. Chaim will give a talk in the session at 10 o'clock that shows the steroid level in the saliva of anesthesiologists who are taking an exam, and it is different than their anxiety level in simulated-based education. We are different animals when we are in an exam setting and in a different setting. So we can't really infer from lab studies on our doings, and we need to dive into the water and learn and improve, of course, as we go.